February CME. This month we're going to expand on some of the information from last month in regards to performing patient assessments, critical decision making, and high-risk chief complaints of abdominal pain as well as neurological issues. A full physical exam should be performed on each and every patient. That is part of being a thorough clinician and will make sure that you don't miss anything, like an ulcer on the lower back or swelling to the ankles, also known as cankles. Also, if you do the same thing every time, it prevents you from missing out on anything due to complacency. Full physical exams are also a good idea from a safety standpoint. We're not law enforcement, so we can't technically search people. However, there have been many times that weapons have been found by completing a thorough head-to-toe assessment, which only makes the situation more safe for you. A focused exam is primarily for someone that has a chief complaint of a broken arm or a broken wrist. They have no other complaints. That does not mean that you won't perform a head-to-toe exam. However, you will focus more on the area that is causing the complaint. Now, when it comes to the history taking, it's always good practice to get it early in the call. That way, if the patient has change in condition or becomes unresponsive, you'll already have the information that you need. It also helps asking the right questions when it comes to gathering information. So you can actually kill two birds with one stone by asking the right questions. For example, if you ask Nana, "Do you take any medications?" she'll probably respond with, "Yes, I do." When what you really want to know is, what medications does she take? So asking, "Ma'am, what medications do you take on a daily basis?" That's going to go ahead and get you the information that you want in a more timely manner. And as for diagnostics, these are going to go ahead and be completed after the primary survey is completed. After you establish that there are no immediate life threats, you will be able to further narrow down your differential diagnosis with the use of our diagnostics. That means blood pressure, capnography, blood sugar, 4-lead, 12-lead, as well as the physical exam. Okay, so there's a story about knowing your equipment. This guy, he owns a boat, and for some reason it broke down, and he had multiple experts come out to take a look at it, the engine, and no expert could get the engine working. So as a last-ditch effort, he contacted an old man that had been fixing boats his entire life. The old man walked all the way around the boat, top to bottom, inspected every aspect, then went to his bag, took out a small ball-peen hammer, and just tapped the engine ever so slightly. And as soon as he did it, the engine turned over and started. The owner was amazed. And how many experts couldn't figure that out, he thought. The owner was so extremely grateful until he got the bill in the mail. It was $2,000. So he contacted the old man and asked him for an itemized bill. The old man sent him a bill that was itemized, and it said, "Tapping with the hammer, $2. Knowing where to tap, $1,998. This story is perfect for us as clinical professionals in many aspects. We don't get paid for sitting at post or sitting at the station. What we do get paid to do is know what to do when people call and what to do when it happens. So if we don't know how to interpret the information from our tools, then we're just ambulance drivers. Knowing what information means when you get it is just as important as knowing what to ask. Now let's look at the tools that we have. Remember also that there are signs versus symptoms. Signs are what we can obtain through diagnostics, and symptoms is what is going to be part of the history information that is obtained, what they actually are telling us. Blood pressure. Why is this so important? Well, it tells us that if somebody's experiencing pain, it will probably be elevated, or if someone is having an ischemic stroke, it will also be elevated. Conversely, low blood pressure will explain why somebody might have had a syncopal episode. We are required to have at least 2 sets of vital signs 5 minutes apart. However, having more than that shows us that we are thorough and that you have more evidence of trending. Pulse. Now, we don't need a fancy machine to tell us rate, rhythm, and quality. All you have to do is touch the patient. So let's not forget to put our hands on the patient. That will go ahead and give us skin temperature, which is also very important. And lung sounds. This is kind of a lost art. What's the difference between rales and rhonchi? That can be difficult for some people to determine. However, history gathering is good and will let you know if they have a history of CHF or pneumonia, which can help us guide our clinical decision making. Blood sugar is also important. Does everybody need to have their blood sugar taken? It depends on the complaint, right? Good answer. So if Nana tells you that she tripped over her dog and scraped her knee and does not have diabetes, blood sugar? No. She tells you that she got dizzy and then tripped and takes metformin, yes, check that person's blood sugar. See, it all comes together. Good history taking can lead your decision making. They're all pieces of the puzzle to help you build the bigger picture. Use them and let them guide you. Use the force, per se. Same thing that we discussed last month. We have certain playbooks that help us guide us through our pathways. However, they all revolve around the same concepts. Understanding the concepts and why we do things makes us better clinicians. Use the systematic approach on every call. Why, you ask? Because if you do the same thing the same way every time, you will not miss things, and the patient has a better outcome, which is what our goal should be for every patient. Example, you get a call for seizures. The husband is the caller. No history of seizures in the call notes. You walk in, you find a 65-year-old female seated in a couch. What do you do? What do you do? You follow the systematic approach. As you approach, she's not breathing. You can't tell. Is she responsive? No, she's not. Is she incontinent? Yes, she is. Then you touch the patient. Ma'am? No response. You feel for a pulse? None. That's how the primary survey works each and every time. It leads you to where you need to go. There are different variations of this when it comes to trauma with PH-TLS. When it comes to pediatrics, we use the PAT, but generally it follows the same pathway to have the best possible outcome for each patient. Lung sounds. Like we discussed, this is kind of a lost art. What is the difference between rales and bronchi, like I said before? This can be difficult for some people to determine. However, gathering that good history will let you know if they have a history of CHF or if they have pneumonia, which will help guide your clinical decision making. Now let's listen to rales. Keep in mind, this is usually heard on inspiration, not exhalation. However, it can be heard on both. If you have a patient that has normal capnography and you hear no lung sounds in the bases with elevated blood pressure, have a higher index of suspicion of congestive heart failure. That's based off of your assessment and can narrow down your differential diagnosis. People don't usually call EMS when they are okay. They call when they are past the point of okay. So let's treat them as such. Now let's listen to what should be another lung sound. This is bronchi. This is usually caused by the buildup of mucus in the bronchial tubes, usually caused by an infection, whether it's from pneumonia, aspiration pneumonia, or chronic bronchitis. We don't know. What we do know is that they are sick and they are more likely to be septic, so we should use further diagnostics to either confirm what we suspect or invalidate the current differential diagnosis. Let's listen to the lung sound that can usually be heard from across the room. Wheezing is caused by narrowing and spasms in the small airway of your lungs. This is due to bronchoconstriction, usually caused by COPD or asthma or even an allergic reaction. So when we hear this in our primary survey, we should probably go straight for the capnography to confirm what our assessment is leading us towards, which should be an obstructive airway issue. Now let us hear a lung sound that isn't really a lung sound. Now when we say lung sounds, we're talking about a sound that can be heard by listening to all 5 lobes of the lungs. However, stridor is usually caused by an upper airway obstruction, something like swelling of the vocal cords, possibly even anaphylaxis. So when we hear something like this, we need to make sure that we have a higher index of suspicion that the patient will have a significant issue and must be treated appropriately to determine the cause of the stridor. Either way, No matter what the presentation is of the patient, it's always the best practice to listen to lung sounds to either rule out a differential diagnosis or to rule something in. So let's listen to the lungs. Skin conditions are a great way to assess a patient from the doorway as part of the cardinal presentation. So let's not forget to pay attention to how our patient looks and presents when we walk in through the door. Let's look at this picture right here. What is their complaint? Was it syncope? Was it nausea? Was it abnormal lab values? They all pertain to a patient with skin that presents this way. So it's our job to determine what the cause of the complaint. So let's do our job and figure out what could be causing the issue. So let's look at the skin. What did we decide? Very good! Mottled. Mottled skin can be signs of many things, from shock, whether it's septic or hemorrhagic, poisons, or even burns. No matter what the cause, it is an indication of poor circulation. So as a clinician, we need to have a higher index of suspicion for poor perfusion and treat each patient with mottled skin as such. Now, let's look at this next slide. How is this patient presenting? If you walk up to a patient with a chief complaint of difficulty breathing and you see them presenting this way, what are your first thoughts? Great, they are cyanotic. So the patient is probably having some sort of respiratory issue, and we should perform some other further diagnostics to confirm what is the cause of the respiratory issue. Diagnostics like capnography and pulse ox, as well as the cardiac monitoring and blood pressure. They all play a part to direct our differential diagnosis. Okay, so you walk in and you see a patient presenting like this. What are our first thoughts? Call notes. Was it chest pain? Was it nausea? Was it a syncopal episode? What did we hear from dispatch is definitely going to play a part in our initial differential diagnosis. No matter what the call notes say, we are going to perform our primary survey and then proceed to our secondary survey and diagnostics to narrow down our differential diagnosis. The patient is extremely diaphoretic. That means that we need to perform some further diagnostics to determine the cause of his diaphoresis. Now that we've gone through the diagnostic tools that we have at our disposal, we also must realize that sometimes we might just not know exactly what is going on with the patient, which brings us back to the primary survey and treating any immediate life threats. Sometimes all we can do is leave a patient better than we found them. So don't assume that you know what is going on with the patient. Always do a complete and thorough physical examination of the patient to determine the cause of the complaint and use your diagnostic tools to help you determine your differential diagnosis. And keep up the good work. Remember, our goal is to use the tools we have to find out what is going on with the patient based off of their complaint. So please, be thorough with your history gathering and your diagnostics. That way you don't miss anything. The primary survey is the most important step in our assessment process and should be treated as such. That way, if there are any immediate life threats, they can be dealt with in a reasonable amount of time to benefit the patient outcome. Also, make sure you are asking the right questions. That way you can gather the most amount of important information in a reasonable amount of time, which also helps achieve positive patient outcomes. Lastly, continue to reassess your patients. Just because they are okay right now does not mean that they'll be okay by the time you get to the hospital. Be that clinician that has a positive outcome. And thank you for your continued education and improvement. Together, we will be the most progressive EMS system. Let's make EMS great again.